Cassidy.
Yeah, I'll go ahead and take my questions now. I agree with some of what my colleague Senator Paul said regarding the adverse, the kind of paradoxical effect of decreasing rebates, but I differ with him on spread pricing. Now, Mr. Constner, looking at your testimony, I noticed that you were not as, kind of hesitated when he asked if it's cheaper to do spread pricing versus a fee. Looking in your testimony on page 20, you speak about your pass-through pricing models, and you say clients pay exactly what Express Scripts pays pharmacy for a prescription in this particular model. Clients receive 100% of the drug rebates that the Express Script gets, and clients pay one simple fee. And in this, the pilot program from 500,000 people was a negative 3.5% drug trend, a 12% total medical cost reduction, $193 in savings from closing clinical care gap, and I really like this as a doc who used to take care of uninsured patients, an 86% of patients that were previously non-adherent to their medications improved adherence through your coaching and intervention. That's a good thing. So a negative 3.5% drug spend. So it's pretty clear from your testimony that bannings are not using spread pricing actually decrease cost by 3.5%. But I think it raises the issue of what is actually the spread. Mr. Joyner, can you tell us what, on those contracts with which you have spread pricing, what is a typical spread?
I do not know the average spread per client because it varies based off the performance of the network.
Got it. Mr. Kostner?
Senator, I don't have the exact amount of where the profitability is.
Ma'am?
Senator, I can't speak to the specific per claim. On some claims, there's a difference by claim. I can tell you we pass through 98% of the discounts, not just in the rebate, but from the spread.
I have limited time. I'm sorry. I don't mean to be rude. Thank you. By the way, I appreciate everything you're doing. I have an article that was sent to me today from first author is Mattingly, Understanding Spread Pricing, How Doctors Flow Through the Pharmaceutical Company for High Utilization Generic Drugs in Medicare Part D. This is Part D. Now, the spread here, Medicare Part D paid an average of $22.50. $3.80 went to the pharmacy, $2.71 went to the wholesaler, $6.73 went for the manufacturer, and 41%, or $9.18, went to the PBM. That was their spread. Now, this is generic drugs and Medicare Part D. It's a pretty good spread. 41% of the Medicare payment for generics is going for spread pricing. Now, I spoke to someone I don't have this in an academic article, but I spoke to someone who has looked at the commercial market, and they have found the average spread is $11.50. Now, I agree with Senator Paul. It should be transparent that someone says, well, wait a second, here we got a 3.5% decrease if we have full pass-through, 3.5% decrease if we just pay a fee. Why don't they just do it? One thing we've been hearing from manufacturers is they have a really hard, from the employee sponsor, they have a really hard time getting this. Now, in y'all's testimony, you say that a third-party auditor can look at this, but that is a third-party auditor for a Fortune 500 company. For the local kind of 200 people employee, they don't have those assets, so I'm told. They're more likely to be fully insured, and the fully insured product is where it's more likely to have spread pricing. I talked to Southern Scripts in Natchitoches, Louisiana, and they charge a fee-based claim with 100% pass-through of everything, and it's $8.50 per paid claim. Now, in Medicare Part D, it is a $9 something spread and with some retention of some percent of the rebates. And here, when it's purely a per fee claim, it's $8.50. So it strikes me, both from your data and from this and from anecdotal data, that the employer is doing better. It's just difficult to figure it out if you're a smaller employer. Now, Mr. Joyner, or one of you, I apologize, in your testimony, you speak about how the average person in a high deductible health plan only pays $18.60 for her prescription. But we know that in a high deductible health plan, you've got an initial deductible of $3,000. Let's just pick that number. And then through the course of the year, you have continued drug spend. So what's unclear to me is that when you are paying list price for a drug, not insulin, because apparently you guys have done a good job of some of these drugs trying to lower it for the person, and I think I spoke to you, Mr. Costner, and you, ma'am, about how you lower it. Hats off, just thank you. But for other drugs, they're paying the full list price when they are in their deductible. It may be $18.60 on the average because through the remainder of the year, they pay a lower price. Have you looked at, and I think I know that 34% of employees nationwide are in high deductible health plans. What is the average cost of a drug when someone, a list price of a drug when someone is in her deductible? Do you all have that data? Because it's $18.60 on the average through the year, but when she's in her deductible, that's where I have a concern. And that's where, if the insurance company knows what her deductible is, and that's what's been negotiated with the plan sponsor, and now she's going to have to pay full freight for that list price because the rebate does not pass to her. The spread pricing is fully operative. She's just paying full freight. Do we have a sense of what that average drug cost is during that period? Mr. Joyner?
I don't have the exact average, but I will say that most of our clients with high deductible plans understand the first dollar coverage and the fact that they want to provide an affordable benefit. So in categories that are attached to the preventative drug list, in many of the cases, the members are paying zero. And then there are many of our customers who choose to pass the discounts through the point of sale, meaning that at the counter, they're getting the discounts.
Do you have a percentage of the customers that would do that relative to the number of patients?
We have over 10 million of our lives in the high deductible plans that are doing that today, so it's a meaningful number.
So 10 million of the 10 million employees who have high deductible plans would get a point of sale rebate?
Exactly.
Okay.
And so on average, our average insulin cost per month
No,
is
but not
$25.
insulin. I'm sorry, that's insulin. I was just talking about drugs in general.
So on average, the average out-of-pocket expense for our members are less than $9 a month.
Again, I'm talking about specifically.
I understand.
Ms. Cianfrocco, let me ask you on something different. You mentioned the margins being 4%. Is that net of expenses? I assume it is.
Yes, Senator, final margin for roughly 4%.
Now, what I've learned is that there's a lot of vertical integration where there's a GPO, a rebate aggregator, others providing data analytics, et cetera, but they're all vertically integrated within the same insurance company, the same pharmacy benefit manager. So if you pay the GPO a fee for whatever they do, and the rebate aggregator a fee, et cetera, one, they may retain a little bit of it, but on the other hand are you subtracting, is that a business expense and you do not include that in the margin?
Senator, for Optum, our affiliated group purchasing organization does not cost the client anything, and
But is your margin net of that or include that?
our margin is straight margin. It's net of everything.
Senator Kane.
Thank you. To my colleagues, I have some